Hi everybody, my name is Aaron Doe, and today I'll be talking about cerebral venous thrombosis, also known as CVT. CVT is a cerebral vascular disease that involves a complete or partial occlusion of the brain's venous system. It is an infrequent cause of stroke in the younger population, accounting for only 0.5 to 1% of all strokes. The mean age of the patients are around 33 years old, and 2/3 of the population are women. In research, the focus of strokes is mainly on arterial occlusion as opposed to venous, but both have similar detrimental effects. So when the venous system is blocked, there are three primary effects. There's an increased venous pressure, a reduced capillary perfusion, and as well there's an increase in total blood volume in the brain, more so local to the area of the occlusion. So why does it happen? There are numerous risk factors that contribute to CVT, some being genetic and some being acquired. Genetic predisposition includes mutations in the listed genes below. An acquired risk, on the other hand, includes things like estrogen-containing oral contraceptives, so birth control, which is actually the leading risk factor for CVT. Estrogen and progesterone increase plasma fibrinogen and decreases antithrombin 3 production, promoting blood clots. Risk is also increased during pregnancy and during puerperium because estrogen levels during those times are higher. The affected brain areas will include the listed four areas down here, so the venous sinuses and the deep cerebral veins. First off, we'll talk about the superior sagittal sinus. This area is affected in about 62% of patients. It's the most frequently affected. So the superior sagittal sinus locally drains the motor and somatosensory areas and are implicit in their function. As well, with the thrombus blocking CSF absorption through the arachnoid villi, there will be an increase in intracranial pressure, which will manifest itself as a headache. As well, there are focal neurological deficits as well, resulting from parenchymal injury, such as hemisensory loss, hemiparesis, hemianopia, and seizures. In the transverse sinus, it'll be affected in about 45% of patients. Thrombosis in the sinus typically causes temporal parietal hemorrhagic infarction due to the occlusion of the vein of Lab. If the occlusion in the sinus is actually local to the left side, it will present aphasia as well. In the deep cerebral veins, this is about 18% of patients that will experience an occlusion in this area. The deep veins drain the deep brain structures such as the thalami, causing edema of the thalami, which will present disturbances of mental status and reduced awareness or even coma. In the cavernous sinus, this is definitely a much rarer case of CVT, however it has characteristic properties that are easier to spot. The patient will experience complications with the eyes, as listed, and as you can see in the picture. What happens is the cavernous sinus drains the blood from the orbits. It receives blood from the ophthalmic veins, so when this is blocked, blood will pool in the eyes and there will be complications there. In terms of diagnosis, it's extremely hard to diagnose CVT because it has no key characteristic features that can help distinguish it. However, headaches will be the most common symptom. They're reported in about 90% of the cases. Stroke-like symptoms will also manifest in about 40% of patients. The stroke-like symptoms do not come on as suddenly as arterial strokes, just because the thrombus will grow slowly and the veins have a collateral contribution. For neuroimaging, physicians will use CT and then MRI in order to diagnose the issue. Using CT will allow them to identify areas of ischemia, parenchymal hemorrhage, and edema. And according to the paper by Ulivia et al., in 2020, CT scans can only actually detect CVT in 30% of patients, so it isn't too confident yet. MRI will be the choice for physicians, specifically the sequencing of susceptibility weighted imaging. It can give an extreme detailed map of the vessels and can, according to Busser and Farrow, show the thrombosis as a hypointense signal, as opposed to T1 and T2 weighted, where it's difficult to discern from regular veins. They'll take the SWY here and pair it with magnetic resonance venography, so MRV, where an intravenous dye is introduced into the patient. The physicians will take these two images and pair them side by side, and they could accurately identify where there's actually a venous occlusion. And that is all. Thank you for listening. Have a wonderful day.